Good morning and welcome to Dr. Ike and Dr. McCoy's tutorial on the labial salivary gland biopsy. We have no relevant financial disclosures. And here are key references that we think are valuable for individuals to review before partaking in the labial gland biopsy procedure. This session is geared towards practicing rheumatologists and providers who require labial salivary gland biopsy in their clinical practice. Therefore, upon completion of this session, participants should define the risks and advantages of labial salivary gland biopsies, have a plan for instituting appropriate pathology scoring of the labial salivary gland tissue, and become comfortable with the technical completion of the labial salivary gland biopsy procedure with an emphasis on suture technique. The labial salivary gland biopsy and the knowledge of how to proceed with the labial salivary gland biopsy fills a major gap in that providers frequently have difficulty finding a dentist or ear, nose, and throat surgeon who is able to complete this biopsy or is available to complete the biopsy. By understanding how to perform the procedure at bedside as a rheumatologist, you no longer have to wait or delay a biopsy for diagnosis or prognosis in Sjögren's. Instead, you're able to treat the patient yourself, which is both good for the provider and good for the patient. Let's start off with the basics, the anatomy of the salivary glands. We have major salivary glands. Right in front of your ear, over your mandible, lies the parotid gland on either side of your face. You have a set of parotid glands producing bolus saliva when eating, along with the submandibular glands right under the mandible and the sublingual glands. Now we're focusing on the labial salivary glands, and you have about 1,000 of these, and they live throughout the mouth. They're pretty much everywhere in the buccal mucosa, aside from certain areas of the hard palate, as you can see sort of in this schematic here, as well in the areas of the tongue. What do these labial salivary glands do? Well, like I said, we know that you have about 800 to 1,000 of them. They produce a small fraction of your saliva, from 6 to 10%. The majority is produced by the major salivary glands and is produced with mastication. We think that they provide lubrication and mucosal protection, and this thought is supported by the composition of the saliva, which is mucinous, has a large amount of immunoglobulin A, has the presence of salivary acid phosphatase and lysozymes, all supporting that this saliva produced by the labial salivary glands is integral as part of our barrier response and protection against pathogens, as well as lubrication diseases. Another diagnostic indication would be for any of the following diseases. Sarcoidosis, as seen here, can be diagnosed on labial salivary gland, as well as amyloidosis, hemachromatosis, lymphoma, and IgG4 related disease. Of course, labial salivary gland might not be the first or best site, but in individuals in whom you don't have a good target tissue for biopsy, it's reasonable to attempt a diagnosis when you have suspicion through labial salivary gland biopsy. Labial salivary gland biopsy also is useful in prognosis in our Sjögren's patients. So we have data that show that if a focus score is greater than or equal to 3, this provides a 98% negative predictive value for lymphoma and a positive predictive value of around 16%. Furthermore, if germinal centers are seen on the labial salivary gland biopsy, there's also marked increased risk of lymphoma. This serves as a prognostic marker through the labial salivary gland biopsy. Also, folks who have a focus score greater than or equal to 3 on labial salivary gland biopsy tend to have higher systemic manifestations. In this study, an SDI around 10 versus 5 in those who had a focus score less than 3. So what is this focus score that we keep referencing? So here I will let Dr. Ike record the history of the focus score.
Sara, I'm sure you'll recall that mastering this little stitch might be the hardest part of learning this procedure. The stitch is opposite what we all learn to use to sew up a simple laceration. Difference being that for this stitch, the knot is buried below the surface as compared to the laceration stitch where the knot is on the top. To achieve this, you take your needle and penetrate the mucosal defect, come up through the mucosal surface, come across to the other side of the incision, and penetrate through the mucosa, bringing the needle back out through the tissue defect, then bringing both ends of the suture up to tie your knot, which you'll be demonstrating. The reason for the vertical incision is this. I admit that for many years I used a horizontal incision. It was a little bit easier to perform, but someone pointed out to me, I forget who, that there are numerous superficial nerves in the lower lip, and they run vertically. So the horizontal incision runs the risk of cutting way more of those little structures than a vertical incision might do, which is a pretty good chance of avoiding them. So that's why I now do the vertical incision. I used a horizontal incision for a lip biopsy. There are some advantages. It easily opens the area to reveal glands to procure. But there is one problem. There are a lot of superficial nerves in the area, and they run vertically. So when you slash across them horizontally, you run a greater risk of transecting one of those little nerves and leaving some numbness than you might get if you incise vertically, which is what I've been doing now for many years and how I teach it. Some institutions that will accept specimens for pathologic review regarding Sjögren syndrome. Two major ones are the two major Sjögren's institutions in our country, the UCSF and Johns Hopkins. For both of those, you can Google and find the access information for pathology by just putting the institution and pathology and consultation. Both prefer glass slides as far as gross specimens. One of them, I forget which, will take blocks for an extra charge and also process those. Our own institutions of University of Michigan and University of Wisconsin have pathology departments that are quite adept at assessing salivary gland tissue for features of Sjögren's. And each of those will take outside specimens as well. Again, getting to the details for submission is a matter of Googling the institution and pathology and consultation. Ah, yes, the elusive focus score. Where did that come from? Well, that focal inflammation is a feature of the salivary glands, and Sjögren's goes back as long as those glands have been examined. The first to bring some precision to this assessment was Waterhouse, a London dental pathologist, examining major salivary glands in autopsy cases. He defined a focus as one with 50 or more lymphocytes or histiocytes, deciding to count the number of those in a 4 millimeter square area. Turns out that the area of view under low-power 10x microscopy is 4 millimeters square. So there you are. He found that quite a few autopsy specimens had some lymphocytic infiltration. The next year, someone decided to look at labial salivary glands as a surrogate for the major glands. The disease being examined was cystic fibrosis, not Sjögren's, but it did establish the feasibility of lip biopsy and pathologic assessment of specimens from lip biopsy as a valid means to assess salivary gland pathology. 4 years later, Chisholm and Mason from Glasgow published their findings in 40 patients with Sjögren's and 60 post-mortem patients. None of the latter had any lymphocytic foci, which established the pathology from lip biopsy as a valid assessment to certify the pathology of Sjögren's. The concept of a focus score, where number of clusters per 4 millimeter square gland is an outcome, was first put forth by Greenspan at UCSF in '74. He was assisted by a couple youngsters, Norm Talal and Troy Daniels, who later on to make quite big names for themselves in the Sjögren's world. Daniels included this concept of focus score in his landmark Arthritis and Rheumatism '84 paper on labial salivary gland biopsy and Sjögren's, which you should all download if you haven't already and plan to pursue this technique in your practice. The elusive and mysterious focus score. That focal inflammation by lymphocytes was a feature of the salivary glands in Sjögren's has been part of the observations going back as long as those glands have been examined. The first to bring some precision to this assessment was Waterhouse, a London-based dental pathologist, examining major salivary glands in autopsy cases. He developed a focus as one with 50 or more lymphocytes or histiocytes, then quantified the number of those as the number occurring in 4 millimeter square gland of tissue. Turns out that the area of observation under 10x low power microscopy is 4 millimeters square, so there you are. He found that quite a few autopsy specimens had some lymphocytic infiltration. The next year, someone decided to look at labial salivary glands as a surrogate for the major glands. The disease being examined was cystic fibrosis and not Sjögren's, but they did establish the validity of bedside lip biopsy and assessment of tissues from that biopsy as a valid means to look at salivary gland pathology in a disease state. Four years later, Chisholm and Mason from Glasgow published their findings on 40 patients with Sjögren's and 60 post-mortem subjects. None of the latter had any focal lymphocytic infiltration, which they proposed established lip biopsy as a very valid means to assess for the pathology of Sjögren's. The concept of focus score that is one of the number of clusters of lymphocytes per 4 millimeter square gland, as an outcome measure, was first put forth by Greenspan at UCSF in '74. He was assisted on this project by two youngsters, Norm Talal and Troy Daniels, each of whom would have quite a career in Sjögren's. Troy Daniels published several years later in '84 his landmark article in Arthritis and Rheumatism about labial salivary gland biopsy in Sjögren's, something that should be in all of your libraries if it isn't already and you plan to pursue this technique. The elusive and mysterious focus score. That focal inflammation by lymphocytes was a feature of the salivary glands in Sjögren's has been part of the observations going back as long as those glands have been examined. The first to bring some precision to this assessment was Waterhouse, a London-based dental pathologist, examining major salivary glands in autopsy cases. He developed a focus as one with 50 or more lymphocytes or histiocytes, then quantified the number of those as the number occurring in 4 millimeter square gland of tissue. Turns out that the area of observation under 10x low power microscopy is 4 millimeters square, so there you are. He found that quite a few autopsy specimens had some lymphocytic infiltration. The next year, someone decided to look at labial salivary glands as a surrogate for the major glands. The disease being examined was cystic fibrosis and not Sjögren's, but they did establish the validity of bedside lip biopsy and assessment of tissues from that biopsy as a valid means to look at salivary gland pathology in a disease state. Four years later, Chisholm and Mason from Glasgow published their findings on 40 patients with Sjögren's and 60 post-mortem subjects. None of the latter had any focal lymphocytic infiltration, which they proposed established lip biopsy as a very valid means to assess for the pathology of Sjögren's. The concept of focus score, that is one of the number of clusters of lymphocytes per 4 millimeter square gland, as an outcome measure, was first put forth by Greenspan at UCSF in '74. He was assisted on this project by two youngsters, Norm Talal and Troy Daniels, each of whom would have quite a career in Sjögren's. Troy Daniels published several years later in '84 his landmark article in Arthritis and Rheumatism about labial salivary gland biopsy in Sjögren's, something that should be in all of your libraries if it isn't already and you plan to pursue this technique.
Here's an example of a foci of infiltrate composed of 50 lymphocytes and surrounded by normal salivary gland tissue. On the right, you see an example of a microscope with a grid. Now, in reality, you obtain a reticle And the reticle will have a grid composed of 1 millimeter squared so that it's easy to count how many millimeters the tissue takes in total, so that you can calculate the number of foci per 4 millimeters squared. Now, personally, having tried to obtain a reticle, it can be very difficult, and I found the most success through reticles.com. Olympus has some reticles available as well. However, I had difficulty with obtaining the correct reticle due to shipping errors. Here's an example of the histopathology in Sjögren's. Here is a normal labial salivary gland biopsy on the left. These slides, I should note, were provided by Dr. Alan Baer, and I appreciate him donating the slide images for this talk. Here are examples of focal lymphocytic stylodenitis with lymphocytic foci. And here's an image of a germinal center-like structure in a lymphocytic aggregate. So there are several pitfalls with the labial salivary gland procedure. One is the pathologist's interpretation of the findings. There is great variability, reader to reader, on the pathology of the labial salivary gland biopsy. So there's about 50% variation in how the labial gland biopsy is read. Therefore, it's important that the provider performing the biopsy has a resource for interpretation of the labial salivary gland biopsy. Another issue is sample adequacy. So we want at least 4 glands typically, but from 2 to 8 salivary glands. Some of this depends on the size of the salivary glands because they do vary in size. A minimal surface area is going to be around 8 millimeters squared. And also, it's clearly beneficial to clarify to the pathologist that you would like a report of germinal centers included. As we discussed, that can be helpful for prognostication. Prior to starting the procedure, of course, we need to review risks and benefits with the patient. Here are the most common risks in the short term. This includes bleeding of around 8%, fainting around 3%, bruising around 2%, pain around 3%, local numbness around 11%, and this would be transient numbness less than 2 weeks, and the risk of infection around 1 to 4%. There are some risks of long-term risks, and this includes granuloma or scar formation and long-term numbness around 2%. Now let us discuss how to prepare for the labial salivary gland biopsy. Starting in the lower left, you see a number 11 scalpel. Next is a 5-0 chromic gut suture. Any absorbable 5-0 suture will suffice. You see forceps without teeth, iris scissors, hemostat. You see a 1 milliliter syringe. Usually I will draw up the lidocaine with epi using an 18 gauge. And then you will inject with what is pictured here, which is a 30 gauge 1/2 inch needle, lidocaine 1 to 100,000 epinephrine. And then I always have several gauze available to sort of ensure that the visual field is clear at all times. And then on the upper right-hand corner, you see a chalazine clamp. The clamp is something that some people use regularly during procedures. I only use it rarely for hemostasis, and the reason it rarely is required is that if you allow the lidocaine with epinephrine to dwell for 5 minutes or so after the submucosal injection, then you really shouldn't need the chalazine clamp because you should have adequate hemostasis in the vast majority of cases. That being said, I do have one in the room just in case I need it. I have our clinic assemble all of these things into a kit, packaged in a biohazard bag, along with a formalin jar so that I can put the specimen in the formalin for pathology. Step 1 in the procedure is to identify labial salivary glands. Here you can see in the light these little bumps, and these little bumps are the labial salivary glands. We're going to want to pick a location that's halfway at the angle of the mouth and the middle of the lip, and also halfway from the vermilion border to the gums. And that's going to be the site of our incision, as you will see shortly. The first thing we do is at that proposed site, we inject 0.4 milliliters of the lidocaine with epinephrine. And most of this epinephrine we want to keep superficial because the glands are very superficial as well. So I give a little bit deep, but mostly I put the medication very superficially where I expect the glands to be. I then allow the medication to dwell for 5 minutes, and I usually set up and do any notation during this time interval.
Sarah, when I started doing this procedure many years ago,
with one simple incision of the scalpel, and
used a horizontal incision to expose labial salivary glands.
And this provides
it worked pretty well. When you pulled the lip out, it would expose that area further and bring out more glands for harvest.
And I am going to go ahead and gently tug out the
I continued that until somebody pointed out to me that there are a lot of little subcutaneous, submucosal nerves in the mouth, and they all run vertically. So if you slash across horizontally, you run a much greater risk of transecting some of those little nerves than if you do, like both of us do now, is to incise vertically. It's a little bit fussier because you can't spread the tissues apart quite as easily as with a horizontal incision. But it's worth it for the amount of anesthesia, dysesthesia you avoid by not transecting those nerves.
Once we finished removing the necessary number of labial salivary glands, again ideally 4, but from 2 to 8 depending on the size, I put in one dissolvable 5-0 chromic gut suture. And we'll discuss how to do this shortly. So to do this suture, we start in the defect. So you'll see where the tail end of that suture is on top. So we go in through the defect on the left, and we come out through normal tissue on the top. Then we loop over the incision, and we come back in through normal tissue and then out the defect. And then we go ahead and tie the knot as is standard. And the knot should naturally fall into the suture, and this allows for more comfort for the patient because they should only with their tongue or gums feel just the flat suture without feeling the knot, which should be tucked naturally into the incision. Usually after I've completed putting the suture down, I'll take the iris scissors and gently tuck, if the knot is protruding a little bit, try to tuck it gently back into the incision. The total incision should run about half the size of a thumbnail or about half a centimeter. Here's an image of labial salivary gland biopsies in their formalin container about to be shipped off. Hello, and thank you for joining us today. We're going to review how to perform a labial gland biopsy in this video. First off, positioning. Once you've discussed risks and benefits of the procedure with the patient, it's time to position the patient for the procedure. I usually put them in a chair and stand in front of the patient. I cover them with a gown, draping it over their front before I start the procedure. Dr. Why don't you please explain to our audience your unique body habitus and how you position the patient? I think this would be helpful. All right, let's go ahead and get started. Here we're injecting 0.4 cc's of lidocaine with 1 to 100,000 epinephrine, using a TB 30 gauge needle in a 1 milliliter syringe. I wait about 5 minutes, allowing hemostasis to occur, before actually beginning the incision. You can see the positioning of the incision is from medial to lateral, about halfway between the angle of the mouth and midline of the lip, and anterior-posterior, about halfway from the vermilion border to the gums. This provides optimal positioning because the labial salivary glands increase in density laterally, but it becomes more inconvenient to obtain the gland tissue physically as you extend laterally. Therefore, this position is optimal. What you can see here is that upon initial incision, we see glands right away and very superficially. I want to emphasize that the labial salivary glands live superficially, and you really shouldn't have to extend the incision very deep at all. Now what you see is we've removed our first labial salivary gland with forceps, and we're proceeding to remove the second labial salivary gland. Upon superficial inspection, we don't see any additional labial salivary glands. I could potentially extend the incision a little bit more. However, instead what I'm going to do is use the incision that I've already created as a sort of window, and I can move it around this very superficial incision such that we can potentially see additional labial salivary glands using this window without having to extend this incision, which I would never want to extend more than about 1/2 centimeter if avoidable. You can see that I'm pointing out an additional gland I could see by moving the window. I'm just releasing a little bit of connective tissue there, and we're going to remove another labial salivary gland. Here we're going to go ahead and place our dissolvable chromic gut suture. We start within the defect, extend out through intact tissue, we then enter again through intact tissue and exit through the defect. This is a simple buried suture. You can see here we've tied the knot. We will then cut the suture right above the knot, leaving 2 little tails. And the next thing to do is to tuck the knot into the incision, burying the knot for the comfort of the patient and to avoid the discomfort of the knot rubbing on the gums before the suture dissolves. I usually at this point provide the patient with post-care advice, which you can see in the associated PowerPoint, and send them home with an ice pack and these care instructions. Thank you. I discuss aftercare with the patients. I recommend that unless they have a contraindication to using NSAIDs, they take a dose of NSAIDs, 600 to 800 of ibuprofen, or 220 or 440 milligrams of naproxen, always with food. I do provide ice, as you saw on the tray, for the patient, and I recommend they ice 10 to 15 minutes on the outside of the lip, and then 10 to 15 minutes off intermittently until the pain improves. And then I do recommend they avoid irritants or foods like strawberries or tomatoes until the superficial wound heals. Regarding coding and billing, we use a code 42405 for a labial salivary gland biopsy. I also always, of course, place a pathology consult. And again, as I discussed previously, you want to find a pathologist familiar with interpreting labial salivary gland focus scores. When I started at University of Wisconsin, I actually worked with the pathology department to perform scoring based on guidelines. And so we actually amended our scoring system in accordance with what is recommended for labial salivary gland pathology scoring. And then you'll, of course, need to document the procedure. And we have an example of the documentation to the right. And of course, this could be edited as per your particular institution. So labial salivary gland is a useful tool for diagnosis and prognosis. And I would again emphasize that in addition to doing the procedure, which addresses a major gap because it becomes within reach of all practicing rheumatologists once you know how to do it, is that you also would need to find a pathologist who's familiar with interpreting these biopsies because they're frequently misinterpreted and also differentially interpreted.
There are 4
If you
institutions
have any questions, then
that will
please feel
accept
free to email myself or Dr.
outside
Ike.
specimens
And on the
for
slide, Dr. Ike
review
can
of
provide
salivary
an example
gland
consent
pathology with an eye towards
that people can,
Sjögren's,
feel free to use as
who will
model
do a
for their
good
own
job
consent
of
if
it.
your institution doesn't have
2 are the big players in
I think it'd be
Sjögren's
handy
in
to
this
go over
country,
a few common
UCSF
questions that we had
and Johns
at our
Hopkins.
2019 labial salivary
You
gland
can get the
workshop.
information on transmittal of
Dr. Ike,
specimens
why
to
do you
them
do
just
a
by
vertical
Googling
incision
the
running,
institution and
from
pathology and consultation.
from posterior to anterior in the
One of them, I
clinic?
forget which, will also take block specimens, but glass slides are what they prefer. At both of our institutions,
frequent question that we
University of
experienced is,
Michigan and University of
Where
Wisconsin,
do we send the labial salivary
our
gland
pathologists
biopsies? We don't
are
have a pathologist,
pretty adept at
at
assessing
our own
salivary gland
institution.
tissue for
Do you have any
Sjögren's features.
recommendations for that?
And both of those institutions accept outside slide consultation. So, as with UCSF and Hopkins, simply Google the institution and pathology and consultation, and you'll see how to get specimens to them. Note that for all of those places, glass slides
Thank you
are
so much,
preferred,
Dr.
so you'll
Ike.
have
I
your
think that
own
was
home
pretty
institution.
And
Do
of
the
course, I think
fixation
before we're
and
having
slicing and
these
staining
conversations.
and placement on slides, and then transmit those slides for assessment if that's what you wish. There are 4 institutions that will accept outside specimens for review of salivary gland pathology with an eye towards Sjögren's, who will do a good job of it. 2 are the big players in Sjögren's in this country, UCSF and Johns Hopkins. You can get the information on transmittal of specimens to them just by Googling the institution and pathology and consultation. One of them, I forget which, will also take block specimens, but glass slides are what they prefer. At both of our institutions, University of Michigan and University of Wisconsin, our pathologists are pretty adept at assessing salivary gland tissue for Sjögren's features, and both of those institutions accept outside slide consultation. So, as with UCSF and Hopkins, simply Google the institution and pathology and consultation, and you'll see how to get specimens to them. Note that for all of those places, glass slides are preferred, so you'll have your own home institution do the fixation and slicing and staining and placement on slides, and then transmit those slides for assessment if that's what you wish.